Hello, everybody. This is Vincenzo Piccolo from Dermatology Unit of University of Campania, Luigi Vanvitelli from Naples. And in this brief video, I'm going to talk about an update on treatment of hair diseases in children. I'm very happy to talk about this topic as we are definitely in the latest year experiencing a revolution concerning the treatment of hair diseases also in children, as we are going to see together. Uh, because time is short, I decided to talk about three main conditions in which probably we had the most important progresses during the latest years, namely alopecia areata, secondly tinea capitis, and the last is androgenetic alopecia affecting children. Let's start from alopecia areata. The problem of this condition that is very common in children is that we have no guidelines for treatment in children, even if a few consensus papers have been published in the latest years, and now from 2021 to this year, two systematic reviews for children have been published. Um, Another issue is that a few randomized trials do exist on treatment of alopecia areata in children, and the highest evidence from the systematic reviews concerns and regards, and this is obvious because they are mostly used by pediatric dermatologists, concern topical and intralesional steroids and contact immunotherapy. From the consensus paper published a few years ago, what is suggested for alopecia areata is topical steroids before 6 in patchy alopecia and contact immunotherapy for more diffuse form of alopecia. When we have adolescent patients, we can propose systemic treatment such as systemic steroids, systemic methotrexate, and more recently the use of systemic JAK inhibitors. We are going to discuss also about two further news concerning topical JAK inhibitors and systemic dupilumab for treatment of alopecia areata in children. As concerning the JAK inhibitors in pediatric population, I choose this paper because it is the most recent paper on this topic, and it's a large systematic review concerning the use of one of the JAK inhibitors in children, that is the tofacitinib in pediatric population. What came from this study conducted on 14 studies and 64 cases is that 47 patients were treated with systemic treatment, while 17 received topical tofacitinib. You see that the rate of responsiveness is quite high after 6 months. Previously, data about other treatment for diffuse alopecia areata showed very low results as concerning the treatments. And when we see the data in a separate way, we see that topical treatment had a 70% of responsiveness, while systemic treatment of tofacitinib given 5 milligrams twice per day reached 85.1% of results. So high response with a good safety profile at age proteinuria, some gastrointestinal upset, and respiratory tract infection as the main adverse reaction to this drug. The same was demonstrated by ruxolitinib, even if this drug has been used at a lesser extent compared it to tofacitinib, but the data are very similar to tofacitinib. The enthusiasm was actually limited by this other paper that has been just published in literature about the flares, so the reacutization of disease during treatment with tofacitinib. In this paper, a subset of patients receiving tofacitinib, in particular 21 patients aged from 6 to 20, with a median age at initiation of 15, and on consecutive tofacitinib for at least 31 months, had 8 flares during treatment. So the rate of flare was very high. More than 1/3 of patients during treatment strangely developed flares. These data were also known from adult case series, both during treatment and also after stopping the treatment. The median time to the flare was 13 months, but what is important and is that 6 of 8 patients remain at the same dose of tofacitinib, just to increasing the dose. And when we have the data about follow-up, all the patients recovered after flare in about 1 to 5 months. So we should inform patients and parents that it could happen, we don't know why, that during treatment with systemic tofacitinib, a flare of alopecia areata can develop. Just to share it with you, this is probably the most important paper about JAK inhibitors in alopecia areata of adults. It is a systematic review and meta-analysis of prospective studies conducted, and what was shown on 1,845 patients, so almost 2,000 patients, is that it's true that oral JAK inhibitors work, but probably the topical treatment is not associated with a better response compared to placebo. But these data are not regarding children. What about dupilumab in treatment of alopecia areata? Dupilumab is a monoclonal antibody that has been developed against atopic dermatitis, and it works very well for atopic dermatitis. And it has been incidentally discovered that dupilumab can work also for alopecia areata when the alopecia is associated with concomitant atopic dermatitis. This is a paper in which the drug was used in 16 patients aged between 8 and 19 with severe form of atopic dermatitis. Of this patient, 4 had an initial worsening followed by improvement. In 4 patients, they noted improvement, and in 2 patients, no change or mild improvement was seen. What was very interesting is that patient with a long-lasting and very important form of atopic dermatitis experienced a better result than patient with without or with a mild form of atopic dermatitis. Another important information is that patient receiving both treatment with tofacitinib and dupilumab better tolerated a decrease of dose of tofacitinib if they were contemporarily treated with dupilumab. This could be a very important information for the future. This is an experience with a patient of mine, a female treated for atopic dermatitis and alopecia areata after 8 weeks of treatment with dupilumab, with a complete regrowth of scalp hair with this monoclonal antibody. So the results are promising. On the same way, we use these other anti-JAK inhibitors that has been approved for atopic dermatitis, the upadacitinib, in patients affected by atopic dermatitis and diffuse alopecia areata. And as you can see, the results are very striking with low or no side effects. What about tinea capitis? A recent paper by Gupta was published on pediatric dermatology about tinea capitis in children, an update of tinea capitis in children. We know that guidelines suggest to use always systemic antifungal treatment as the first line treatment, plus the association with topical agent to prevent the spread of fungal spores. But the problem is that glycofulvin, that is most used to treat the Microsporum canis tinea, that has been approved by FDA since 1958 for children aged more than 2 years, is no longer available in some countries. Here in Europe, there are a few large countries where glycofulvin is not available anymore. So we have we do need a new treatment, and terbinafine has been recently approved by FDA also in children, but more than 4 with the dosage that you see here. But the problem is that there have been found some trichophyton species that developed a resistance to systemic terbinafine, probably due to mutation in a gene encoding the squalene epoxidase enzyme. A lot of evidence is increasing as concerning fluconazole and itraconazole in children. By the way, a double-blinded controlled trial showed a very low rate of cure with fluconazole. So the problem is serious because we need a new treatment where glycofulvin is not available anymore. A few data have been published also about photodynamic treatment in children with tinea capitis. Also, these guidelines, this suggestion for parents can be useful. You can see it on the screen. So whether head shaving is necessary or not, everything has been collected, like the so-called frequently asked questions by parents in this very interesting paper. But there is no time to discuss all of it. Finally, let's see something new about androgenetic alopecia of children. As you know, the androgenetic alopecia is not an exclusive disease of adults. It also affects male and female adolescents. There are a few data about the use of systemic treatment in adolescents affected by androgenetic alopecia with finasteride that is approved for guys older than 18, but a few studies under 18 have been conducted. It seems quite safe in adolescent males aged 14 or older, showing a high increasing hair density with no additional hair loss. But the problem is that some sexual side effects have limited the use in this age category. So finasteride cannot be recommended in pre-adolescent boys and in female pediatric population. But the most important piece of news is a very recent paper published in 1 month ago on the Blue Journal, the Journal of American Academy of Dermatology, about the use of a low dose of oral minoxidil in pediatric population. 14 patients were treated with androgenetic alopecia and telogen effluvium with a mean dosage that is different from females to males. Obviously, females took less medication than males. Just 1/3 of patients received oral minoxidil in monotherapy, the other one with topical or systemic combination. They had an experience for 9 months, but the results for this treatment are impressive. Also in children with androgenetic alopecia or telogen effluvium, the hair density improvement was impressive, 80%. And the remnants, the other patients show the stabilization of the disease with a very, very low rate of side effects, hypertrichosis being the most important one, and hypotension seen in one patient. So just to summarize, which are the future perspectives? In alopecia areata, we should learn and evaluate which is the real life cost effectiveness of JAK inhibitors that are undoubtedly useful for children too, but we must understand the safety profile and which is the real cost effectiveness of this medication. As concerning the dupilumab, which we need to know which is the subset of pediatric patients who can benefit from this treatment, and we need probably guidelines for children. As concerning tinea capitis, maybe the most important goal for the future will be to identify a valid alternative to glycofulvin in children where it is not available anymore, in countries where it is not available. And as concerning androgenetic alopecia, we should confirm the efficacy of oral minoxidil in adolescents with androgenetic alopecia, probably with randomized controlled study. I hope that you enjoyed this presentation, and I thank you for listening.